Good morning, everyone. Give me 1 second. Nice to meet you. We're excited to be here. We'll do a round of introductions. We are expecting the commissioner from the Department for Aging and Independent Living to join us, but well, look at that, right on cue.
Someone here? No. Yep. It's perfect. Hello.
So we're excited to be in Orange County today for Capital for a Day. It's an opportunity as much for us to hear what's happening in the community, to really understand on the ground, what the reality is. Many of the times you'll often hear the governor say, that when people come and approach government, they think about being asked to constantly come to Montpelier. And for us, this is a way to get out and not just ask people to come to us, but to really see what it looks like on the ground. So it's going to be an open dialogue and conversation. We're hoping to hear from folks here. What are some of the things that are going well? What are some of the things that are really working? And then what are some of the realities and the challenges that you're facing on the ground, and things that we can work together to help move forward. So we've got a team from across the agency, from the Departments for Disability and Aging and Independent Living, from the Department for Vermont Health Access, from Healthcare Reform, the Department for Mental Health. And so we'll go around and we'll have an opportunity for everyone to introduce themselves. But I'm hoping that bringing not just the agency itself, but all of its parts will help us have a much more robust discussion and conversation today. So I didn't introduce myself, but I'm Jenny Samuelson. I'm the Secretary for the Agency of Human Services.
Hi, I'm Brendan Krause. I'm the Director of Healthcare Reform.
Dr. Bowen, Jill Bowen, Commissioner, Dale.
Good morning, Doug Foll, Vice President of Support Services here at Gifford Healthcare.
Good morning, Tim Ross. I'm the Chief Financial Officer for the Claire Martin Center.
Hi, I'm Danielle Caton. I'm the Director for Substance Use and Justice Involved Services at Claire Martin.
And I'm Melanie Gidney, and I'm the Executive Director at Claire Martin Center.
Emily Hawes, and I get to be the Commissioner for the Department of Mental Health, formerly from the Claire Martin Center.
I'm Ashley Lincoln. I'm the VP of Development and Public Relations here at Gifford.
I'm Mary Block. I'm the Director of Insurance Regulation at the Department of Financial Regulation.
I'm Rebecca O'Berry. I'm the Vice President of Operations here at Gifford.
Hi, I'm Ursula Margazan. I'm the Vice President of Senior Services for Gifford and the Administrator of Record for Many-Yard Nursing Home.
Monica Boyd, Vice President of Quality and the Compliance Officer here at Gifford Healthcare.
Michael Acosta, CEO at Gifford.
Hi, good morning. Johanna Belleville. I'm the CEO with Visiting Nursing Hospice for Vermont and New Hampshire and White River Junction, serving in Orange County.
Tammy Tarso, Chief Clinical and Operations Officer for Visiting Nurse.
Jill Markowski, VP of Nursing here at Gifford.
Josh White, I'm the CMO here at Gifford and an emergency physician.
I'm Ken Hammond, I'm Field Services Director with AHS for Hartford and Barry.
Julia Rowe, Deputy Commissioner at the Department of Health.
Mark Levine, Commissioner, Department of Health.
Deshaun Rhodes, DEVA Commissioner.
Hi everybody, Monica Hutt. I sit in the Governor's Office and I'm the liaison to the Agency of Human Services.
So on that note, Monica, is there anything you want to add to our introduction?
No, I think that Secretary Samuelson said it really well. Capital for a Day was started years ago and is really an opportunity for the Cabinet, Governor's Cabinet, to be out in the field and to hear from you directly. Healthcare obviously is currently on everybody's mind and lots of topics of conversation. So I think that this is a particularly opportune moment to hear from you all here in Orange County and to hear from Gifford directly. So thanks for having us.
So I know that this is, having worked with many of you already, it's a shy bunch.
Not a talker.
Not, there's no talkers in this room. So from here, we know that the landscape right now in healthcare has got a lot of kind of bumps in the road. And we thought we would start off this morning, though, really talking about what trends you're seeing in your community. What are things that are happening here and on the ground that we might not know, or that we might know but that you want to amplify?
I would defer to others. Go ahead.
I don't mind going first. So I'm Melanie from Clara Martin Center, and for those that may not know, I'm one of 10 designated agencies in the state of Vermont. Our agency is actually unique in that we provide mental health and substance use services, but our developmental services is through Upper Valley Services. So it happened in the mid-'80s. Not really sure the history behind that, but we are unique in that way. I would say trends that we're seeing, we are definitely seeing an increase in demand, an increase in acuity, an increase in co-occurring issues. And when I say co-occurring or integrated treatment, mental health and substance use. And I think if Gloria Quinn was here, she would also agree that she is seeing an increase with developmental services folks with mental health and substance use, so across that whole continuum. We also are seeing a trend locally of actually a reduction in Medicaid referrals, but an increase in private pay, third party, and Medicare, which is Tim's been trending this over 5 years, and Medicaid's going down and those are going up. So the people we're seeing are the same, but that payer mix is different. And the payer mix is really complicated because Medicaid gives us more flexibility for having people that are on the roster. I'm not sure the language here if people understand it, but for Medicare and third party, they really require a license, credentialed, and we don't have access to, there's not enough credentialed staff in the state of Vermont, clinicians to do this work. So both from that aging population that we are definitely seeing, the demand for Medicare licensed practitioners is great. And so we are challenged to meet that capacity right now with the aging population. In terms of funding, I think we all know the story. We are definitely seeing increased costs. We really struggle to pay a competitive wage to recruit those credentialed licensed practitioners. So for the DA system, it's an advocating with the administration and with the legislature to invest in our system. We like to think of it investing in our upstream preventative services to help bend and turn the curve. I'm really proud of the work we've done here at Gifford. I feel like we have a strong partnership at working with people that are using the ER and trying to prevent people going to the ER, whether it's through our mobile crisis or just our partnership with Gifford at supporting each other with our different competing demands. With those funding challenges, I think Clara Martin Center, 6 years ago, made a strategic decision to apply for a CCBHC grant. And CCBHC is a certified community behavioral health clinic. We were the first in the state to be awarded a 2-year grant, and then we subsequently got another 4-year grant that we're in year 3. And I'm just really proud of our work with the Department of Mental Health. The state, with AHS's support, has become a demonstration state, and we're in the process of working with GMH to hopefully be certified come July 1. But that was strategic for us just to diversify funding to try to stabilize access to mental health and substance use services in a very rural area. We serve the greater Orange County, so from Randolph to Bradford, and then we have substance use as a preferred provider down to Wilder. So it's a very large rural demographic. One thing I like to highlight is we are part of the response to the opiate crisis, but I think something that can get lost in that is alcohol is still our highest diagnosis, substance use diagnosis.
Number 1 in the nation.
Yes, and both need equal attention, but I think alcohol can get lost in some of the discussion and all of the societal impacts of the opioid crisis.
And are you saying, I know that Clara Martin has been at kind of the center of that substance use work for a long time. What are you saying changing on the ground today versus 10 years ago?
In terms of substance use, specifically, definitely, as Melanie said, alcohol just continues to trend upward, and that is consistent with national trends. I think that specifically Vermont and Orange County, the unique impact with an older population and the complex medical needs that people with alcohol use disorder and substance use present with when they're over 60 is really significant. And I would imagine that Gifford and our visiting nurses can attest to that. That it just makes that coordination between providers and medical staff even more important, and is also interwoven with us seeing people with substance use issues who are older and are frequently more unhoused or having housing insecurity, and just the complexity that that creates, especially in our geographic region where I'm located down in White River Junction, but within Orange County, it can feel like our unhoused population is a lot more invisible, that we're not, you're not necessarily driving down the road and seeing an encampment throughout Orange County the way that we do in White River, but that things can be more hidden based on just how we are geographically.
And I think the only thing I would add to that, Danielle, is just the social isolation and loneliness as people age and the higher risk of substance use and alcohol in particular. And it circles back to the Medicare and some of the restrictions. It really pays for therapy and it pays for psychiatric care, med management, and what they need is really that access to case management, supportive counseling that the Medicaid population provides for mental health, but Medicare is really restrictive. And I know we are trying to advocate at the federal level for some of those Medicare changes to loosen the credentials that are required to bill, and just would love both from the third-party insurance and Medicare to support and reimburse for case management. And really that community connection, which is what people need, is us connecting them to other resources, other people. And that is prohibitive because Medicare doesn't cover those services. So we got the grant to expand access, and then we hit all these roadblocks of treating all payers the same. And I think, I think sometimes that's misleading around the community mental health center is that we provide therapy. What I think I'm proud of is that we have a whole continuum, a whole system of care, of wraparound supports and vocational and mobile crisis that's just developed over, exponentially over the many years I've been here.
So that goes to kind of like the what's going right. Like it sounds like there's a lot of strength in what you're bringing to the table.
I think our strength, Emily, Commissioner Haas is really trying to embrace the CCBHC model, the clinical best practice that it is, the training support to bring those cutting edge models to rural Orange County, and partnering with the state to implement that and work with the statewide system to raise the bar where we can. But it is incredibly complicated. The other thing that I would say is going well is we may be unique. We did have a wait list, a significant wait list over a year and a half ago. But we are proud to report that through a system change and working with a national consulting firm that we have same-day access now.
Wow, that's really impressive.
And we have no wait list, and I say that with a caveat that for psychiatry you might be waiting, but you could Monday through Thursday come to Randolph or Wilder or Bradford Monday through Thursday for a 5-hour chunk of time and walk in and get an assessment. And we will assess and refer from there, and that's just embracing the right time, right place, that we know with mental health and substance use, you've got to be available and accessible when they need you. And that if we gave them an appointment 2 months, 3 months down the road, they either found somebody else, decided they didn't want treatment, or continue to struggle. So we're in a system change with that, but I think we've seen really positive results. So we're proud of that.
And that's for both mental health and substance use?
Mm-hmm.
Is that mostly new folks walking in or both? Okay, and can you do medication renewals there?
We are working on same day in time, just in time, thank you, with medication as well. We're a small agency, so we have one full-time medical director that sees a whole caseload, and a nurse practitioner, but we are trying to work with them to follow the same model, so that when people need it, and then we've been great at working, or Gifford has been great at working with us around working with PCPs, so that we'll do a case consultation, we'll get them initiated, and once they're stabilized, work with the PCP office to free our resources up for new patients or high-risk folks.
I don't want to misinterpret something you said, so I'm going to try to explore it. You talked about Medicare, the need for a licensed, credentialed clinician, and obviously the financial impacts that that has, and the workforce impacts that that has, because they're not all around to hire. And differentiated that from the Medicaid system, where the level of care, or the level of the caregiver is different, but works quite well for that population. And am I kind of hearing you saying, if it wasn't for this Medicare rule, we could do the same system that works quite well, and it would work quite well for the people who qualify for Medicare?
Yes. For Medicare, it used to be only a licensed clinical social work could bill Medicare. That did recently expand to clinical mental health counselors and licensed marriage and family therapists. Interestingly, with the older adults with a high risk of substance use, a licensed alcohol and drug counselor isn't permitted to bill Medicare. So we've been trying to work to advocate for that, just that change. But that only pays for therapy and bed management. So if I have a case manager that I want to go to an older folks home and connect them to the senior center and sit with them to have lunch and build their own social support network, Medicare does not reimburse that. On the Medicaid side, absolutely, licensed clinicians are great and we can bill, but also for master's level therapists, there's a roster program that you can go on the roster for 5 years and provide clinical services under supervised billing. So you're under the supervision of a licensed clinician. But in addition to those services, case management, support, peer services, I think that's a new trend for us, is the employing people with lived experience and how well received that's been by the people that we serve. But yes, Medicaid has a whole continuum, so much more flexibility, and yes, that's helpful, and it has its own challenges too. It's a mixed
better
message.
outcomes, and really increasing folks' accessible opportunities to care.
Okay, I suspect we'll hear more about that in the healthcare reform.
Can you highlight one other, I think, operational change that I think was valuable for your system? And maybe that was wrapped up in the same day access, but also centralized scheduling, which I do think is something that's valuable for folks to know how that evolution occurred, because I do think that
It goes hand in hand.
Yeah. And allowed for that same day access opportunity to take hold.
Would you like to take that one?
Sure.
You were in the heat of system change.
Heat
and
is correct.
perception of control of clinician schedules.
Well, I think it came from just a desire to not have master's level clinicians doing administrative work that could be done better and more efficiently by our admin staff. And I know that within healthcare, that's always a huge challenge is, we have clinicians who they're $100,000 in student loan debt because they wanted to do therapy, and we wanted to do as much as we could to remove what administrative burden we could to allow them to do that. And then the other piece is scheduling, clients really being empowered to schedule with a clinician at a day and time that works for them instead of based on what the clinician prefers or the clinical staff prefers. And it helps us keep a true understanding of how many clients are engaged, what's the frequency at which they're engaged, and we can better understand where we have room and maybe where we need to do some Tetris with, we have some space here, so can we move some Medicare clients here who could be seen with a person who could bill for them. So it was just about becoming more efficient, but also meeting the clients with what they need. And it's not based around what works for staff, it's based around the client experience and their preference.
Thank you. Yes, that was perfect. Yeah, great.
And just because I've been asking this around the state for the more clinical people in the room, the penetration of use of medications for alcohol use disorder, uptake of that, is that happening here?
I can't speak to Dr. Buchanan's rate specifically. We have a medication-assisted treatment program averaging between 20 and 25 clients. And then Dr. Buchanan and our psychiatric nurse practitioner also prescribe alcohol use disorder medications with individual clients who they see and prescribe for. And I know within Orange County, there was a lot of work done by DSU to open up access and to allow that to be more rapid, not just within DAs, but whether it's emergency rooms or other outpatient treatment providers.
I don't think we've seen a big change in medication use for that here, clinically speaking. I guess to add to what these folks said, I completely agree. The major issue here is opiates are real and they're a problem, but that's not the big problem here. It's alcohol. And as a lived experience as an ED clinician, I don't remember the last time I pushed Narcan. It's alcohol, alcohol, then opiates.
And is the alcohol much worse post-pandemic than pre-pandemic, or is it just a trend that's been going on?
It is worse, and that's consistent with the mental health crisis. I would say that the work this team has done, our psychiatry and counseling division here has been pretty exceptional in addressing that. There's still a pretty significant need. The workforce issue has been a major contributor to the challenge in addressing that. That being said, telepsychiatry has been a pretty significant way in that we have addressed it. It's a problem we're not going to be able to out-hire locally. I don't have numbers. It's worse, but it is not something that I would be able to measure.
You have depression diagnoses that go along with that?
Oh, yes. Yes, they're hand in hand.
And I think to the alcohol piece, specifically with our aging population, not under just education needed around how alcohol impacts their body very differently than a 25 or a 40-year-old. So there's a lot of opportunities just to educate older Vermonters on what that can do to them physically and medically.
Do you have a program like that going? Currently, do you have a program like that going?
That would be a question for our CHC team. No. And I would add to that and say younger Vermonters. I have children in school. They get hammered on the problems with drugs. They have zero concerns about alcohol. They will, tell you about the terrors of marijuana, but think nothing of the concept of alcohol. And I think that is a very misguided educational directive.
I think that link you made before with the social isolation factor is very prominent in rural settings.
And then impacts their ability to attend things like AA or training programs unless they can potentially be hooked up to, virtual, but still, it's not as good as being in person, especially with substance use.
I think the isolation part is a major factor in what we are seeing here as far as trends go. We have a large patient population that is functionally immobile. They can't get elsewhere. They don't want to. They're Vermonters. They don't have a ride. They can't get another day off of work. They're for their own individual reasons stuck here, and it's produced a pretty significant patient distribution problem. As you might expect, over the years, medical technology has markedly enhanced a lot of care, and we've seen our inpatient census drop, and a big driver of that is quality. You have an orthopedic surgeon that could replace your hip and send you home same day with Tylenol, and 10 years ago you would have spent a week. As an ED physician, I very rarely admit chest pain anymore when it would have been one shift 10 years ago. So those people who've gotten quite good at keeping home, at the same time the patient population is elderly, the number of chronic illnesses and the disease burden is going up, and the need for tertiary care has skyrocketed, and there are no beds for them. And so the basic things have moved out, and they're fine, but the complex things have increased, and people can't move around. The routine argument I have in the emergency department is, you need to go to Dartmouth. We're about 10, 15 minutes closer to Dartmouth here. And the patient, well, no, the cows, you're having a heart attack. Well, I can't take another day off of work. These patients won't go anywhere, and we have a pretty significant distribution problem that time and technology have markedly enhanced.
Josh, I would add. Go ahead. Just within Orange County, the lack of internet access, I think for many of our areas, I think is a challenge for even that telehealth option, which has been really helpful. I think for our organization, we still believe face-to-face is best, but it's just given us the flexibility where we needed it. But transportation, the accessibility to the internet and portals now, people just don't have, I think there's an assumption at times everybody has access to that and they don't. And I think just the last thing I wanted to mention for us is just the housing. I'm preaching to the choir, but both from a staff recruitment perspective and the social determinants of health, just for finding affordable housing for the people we serve is significantly challenged. And without that foundation, I think we all know people are not as well as they could be.
Do you have any community nurse?
So what I'm hearing a little bit is, on both of these sides, a theme is kind of the evolution, right, of the way that we are practicing, whether it's medicine or practicing healthcare and mental health services. The complexity of what both of you have talked about a little bit with the interaction, before it was our communities and our people. When I'm hearing you say it's our communities and our people, but they're now interacting through telemedicine, through general the differentiation of the tertiary medical center and the local hospitals in a very different way with their health and medical community. What does that look like for you now and then 5 and 10 years from now?
I think just my opinion, is that Vermont's conversations about changes in healthcare practice generally have an underlying assumption that our system functions very, very well. I'm not sure that's true. I think everything Dr. White said about, hey, there are people that used to stay here for a week that now go home in a day is 100% true. But we know there are people stuck at UVM who we call and say, you're full. You have people boarding in the ED. We have space inpatient. We can take care of them. We'd love to send them. What's the obstacle? We're just not good at sending people, right? Hey, we talk a lot with the state about our funding rates, and I think that's a legitimate conversation. Are we great at billing and collecting for every single thing that we do? Probably not great, right? And so I think it's hard to figure out what's changing, what has to change because care is evolving, and demographics are evolving, and what's unused capacity because Vermont's healthcare system has a hard time getting out of its own way. And I think we're struggling with that right now. It's like, how do you pick the right pathway in the future when you're not entirely sure how solid your operations are in the present? And then you're not sure how much time and effort to spend fixing those things, because you could be in a capitated model in 2026. You could have a statewide transfer center at some point in the future. And so for me, one of my hopes is that in this next iteration of healthcare reform, we focus really hard on how to get the right patient to the right place at the right time, right? Because you might be able, if you've been waiting 5 months at Dartmouth for a very simple surgery and your critical access hospital has plenty of OR time, it feels like that could be a win for the patient and for the local hospital and for Dartmouth, because Dartmouth and UVM do truly extraordinary things. And those places work better when they're doing the things they're supposed to be doing, as opposed to things that could be done at Copley or Gifford or NVRH, right? And so I think sometimes we skip over performance to get right to visioning. I feel like I could be a better partner on the vision for the future if I understood, like, hey, this is how we really should, this is where Vermont's system would be if it was a high-performing health system. I'm not sure everybody agrees with that, but that's sort of my view as the new guy.
So let me probe that a little bit and then throw it out to everyone else. What I'm hearing you say is, hey, get back to the fundamentals, our systems, not in that, like a few years ago, we talked about flow, right? And flow through the system as one of the primary priorities. And we've done a few things as a state to address that. You know, Clara Martin Center and others have looked at what does mobile crisis look like for mental health. We've looked at, you know, long-term care and where we move patients there. But, you know, those fundamentals in terms of the way that we care for people are so important to then scaffold the payment systems that are necessary around them. So the other, you know, it's not just the payment, but it's the data systems around them and the others. But what is it that you're seeing on the ground that are those fundamentals that you would focus on? And what are driving both the things that are working and the things that aren't working in those practices? Because I'm hearing it, I've heard it from home health agencies and other parts of the state, is that that's a core part of the problem. I've heard that it's mental health and the substance use. I've also heard that it's the hospitals. But
yeah.
So from a local systems perspective, very small, what does that look like?
I will give people 20 seconds to formulate their answers to your good question by saying, one, I agree with your formulation that, hey, let's get back to the fundamentals. And for example, when I was at the Department of Vermont Health Access, I didn't like to spend $1.50 on something I spent $1 for. I was much more inclined to try to reward the doers. If you could show me, hey, we've done everything we can to maximize our grant funds and our revenue cycle is great, and we take care of people in this innovative way, I'd want to pay more for that rather than just, hey, I'm going to pay $1.50 for what I used to pay $1 for. And so like a paradigm where it's back to the basics and we can, people who are showing they're doing better get paid better is like really interesting paradigm. I'd let other smart people jump in on your question.
Go ahead.
I don't know if it answers the question specifically, but what I'm thinking about as I'm listening to this conversation, I'm Johanna with the Visiting Nurses, is, you know, for thinking about the skilled home health work that we do, right? So obviously we can be and have been really important partners to the state in terms of the long-term care services that we're able to provide. But skilled home health care is predominantly a Medicare program. And so we don't have the same opportunity at the state level to talk about ways to innovate and be a better partner for that throughput and continuum of care needs. And, you know, building on the theme that Melanie started, right? The patients are sicker, they're higher acuity needs. The Medicare benefit only allows us to do so much on an intermittent basis with people, and as our population becomes older and more socially isolated and dealing with all of the things that the team here has already raised, there's a real gap between what home health can do and when they've met their goals from a skilled need perspective for Medicare and how to access the rest of the wraparound services, particularly when they're homebound, isolated, and quite honestly entrenched in their own ways of wanting to do things. So I don't have an answer to that, but I need to acknowledge it in this forum that that's a real conundrum for us in the home health world around how do we best partner. What are the flexibilities that we can potentially work towards, recognizing we're really constrained by our payment models and Medicare continues to cut rates.
I agree with you. I guess one question I would have, if I may, is, as you know, I used to work in FQHC and home health up in the Northeast Kingdom, and I won't name any hospitals in the Northeast Kingdom, but you know, home health rates are predicated in part on quality measures like readmissions. And so when hospitals would say, we just gotta get this person out of here, and you send them home and they need a level of care that is way beyond what home health can handle, and then they go right back in, it's a way in which you are getting penalized by Medicare because the state's healthcare system is not performing as well as it should, right? So there are some opportunities, even if Medicare still remains the prime driver and is not within the state's control. Right?
That's fair.
And I don't know if those systems are even in place. So to get back to maybe your point of getting back to the focus, getting back to the foundation of caring for people, we see gaps, and I've listened to everyone speak, and the gaps are the same across the board, but there are gaps that are they're just not filled in the current system. And so when we look at these high acuity patients who are being discharged, because we understand that hospitals need to free up the beds for other acute patients, we can go in and provide some skilled care, but we can't make sure they're taking their medications. We can't make sure they're fixing their meals. We can't make sure they're getting out of bed to use the bathroom on a regular basis so that they're not developing additional wounds. That is not what we do, and there's not a mechanism for that care because there's not a mechanism to be reimbursed. And so while we would all love, I think, to sit around and say that we're providing this care, we're not, because it's not a sustainable model for any of our organizations. And that, I think, is one of the things that we need to think about as a state. If we say that we care for our community members, then we need to find a way to care for them, and that is going to require a reimbursable model.
The caregiver shortage is significant, and we talk a lot about our paid caregivers, right, in terms of and thinking about long-term care specifically has been top of mind in lots of conversations, and the inability to attract and recruit enough personal care assistants to do the work Tammy's describing, which is really helping people to stay independent at home. But there's a caregiver, a family caregiver crisis and shortage as well. We have more and more older adults that are really truly isolated, that don't have a network of people to call upon, and we don't have the system, as Tammy was just saying, to provide that service in a way that we can pay for it and sustain it and attract people to do the work. Right.
So I've heard a couple of themes here. I just want to make sure I've got it right. Like right care, right time, right place, and that's that focusing in some cases on that. I've also heard entrenchment, which is a theme I haven't heard in any of the other communities, and so I wanted to call that out a little bit. But where we've been most successful, in my experience over the last few years, is to be able to really identify and call out those gaps. It's not just gaps in payment, but because gaps in payment doesn't tend to resonate. It's gaps in care. The substance use work that we've been working upon recently really has highlighted that incredibly well. We've done a lot to strengthen our mental health system over the last couple of years, and we've identified some gaps there, and we're able to really work towards fulfilling them, like one concrete piece at a time. Now we're kind of embarking on that with substance use, but I don't want to assume that we're all looking at the same gaps, because we all talk as if that the gaps are inherent and known. What are the places that you're seeing those gaps, and then how would you prioritize them? Like what are the ones that, as a group, between the designated agency and the home health agency and the hospital, like what are the gaps that you can jointly agree on, and how would you prioritize the ones that are the most impactful to address first? Because I don't want to assume that everyone's talking about the same gap.
So I can give an example. So I had a conversation with some hospital representatives from DH on Friday. We have a patient that needs to be discharged. He's been into the hospital at least twice a month for a diagnosis. He needs to monitor his blood sugar. He's homeless, so he's currently staying in a hotel. We can provide education. We can't go every day, which is really what he needs. But for us, that's where we see the gap. So we can go and do part of the work to help keep the patient out of the hospital and lower that readmission rate, but we can't do all of it. And he doesn't have family, so there's no place to pull from to help keep this gentleman in the community, out of the hospital, and as healthy as he can be.
So his natural supports just aren't, like what I'm hearing is the isolation factor kept coming up over and over again, but what I'm hearing is the breakdown of those natural supports for many of our clients.
And there is, I would build on what Tammy just shared in terms of, it comes back to the acuity of the patient being discharged from the hospital. So whether that is impacting readmissions or just our inability, right? So the skilled home health program is not designed to provide the level of care and service that many patients today, not all, but many patients today need in that post-discharge, that immediate post-discharge episode. And we're too rural to take advantage of things, like hospital at home waivers, right? Because we don't have the service capability to deliver on everything that an inpatient environment would deliver on in our home setting, in our rural environment. So that's the gap in my view that we really need to figure out how to close, is how do we continue a level of acuity at home that's not quite the hospital at home model because they don't qualify under those waivers, but that there's some additional support for people.
Are you talking about something that would look like a different type of facility or a swing bed, or it'd have to be inpatient? Like, what would be the appropriate setting for the person you just described?
So it could potentially be swing beds, which I know we have access to that throughout the state, although that's not my world right now, so I don't know what the capacity is there in terms of supply and demand. But I do believe that there is a subset of patients who could be cared for at home, who have a slightly higher level of acuity than what, again, the Medicare home health benefit is designed to deliver upon. But we don't have a way to do that. Like we're in home health, we're not reimbursed for telehealth programs. And so again, I'm raising a bunch of issues that for us are federal, but it impacts Vermonters. And it impacts our ability to really partner and innovate at the state level because we're so held to the federal.
Create those restrictions and the creativity of the Medicare program, things that we would wish to do in Vermont. I know we have ideas and we would want to test out, but haven't had the capacity to do because of the federal restrictions. And so we would need the funding and the flexibility to do that.
Correct. Thank you.
I just want to summarize what I heard and see if we're all hearing the same thing, because I'm hearing a minimum of 3 reasons why there's dysfunction in the system. One is for the highest acuity patients, which are now the more common patients, as opposed to the rarities. There sometimes is not an existing model that the workforce that you have is trained to deliver that, to meet the needs of those patients. The second thing is sometimes there is that, but there are services that are not going to be reimbursed, so you have to sort of prioritize what you are doing and how often you're doing it. And then the third reason is actually payment. Am I hearing it right?
I think some of that model is present in terms of where to care for these patients. We have, if I recall correctly, based on the census this morning, 15 open beds.
Mm-hmm.
You've got people that have been sitting in the ED waiting for placement at UVM and Dartmouth day after day after day after day after day. We call them the stuff that oftentimes they can't get themselves together to transfer. But then when they do, I think the last one we were confronted with was, well, you can have this guy. He has a medication need that costs $20,000. Like you can have the undesirables. they see us as an outlet for their financial problems, not as a partner. Like, the system is there. There is capacity, especially in a lot of these little hospitals. I mean, the way we got ourselves here is we're doing the things that everybody wants. You know, nobody wants to stay an extra week in the hospital because you have pain. And so we're shooting ourselves in the foot by increasing quality and losing, but have open capacity. But the system is not designed to shift patients around. Hospitalists are not trained in the middle of care. You know, this patient might need a couple more days of diuresis for CHF. That's fine here. We can do that. We don't need to do a cath here, a cardiac cath here. The larger entities see themselves as, and or just aren't able. It's very insular. This is our thing, and you're out there. And there isn't a movement of patients. Capacity is there.
So just to make a distinction, maybe Jill can talk about it. I mean, one of our hypotheses about how to best serve our community and to shore up our finances is try to transfer people from an academic medical center into Gifford. That experience so far has been different between Dartmouth Hitchcock and UVM. Do you want to talk a little bit about how it works and what the challenges we've seen?
Yeah, so we participate in a huddle each day with each of those healthcare systems, and we go through what is the capacity in all of the participating organizations, and we would try to get the right patient in the right place and move them there. You know, we hear through the UVM network, you know, all of their capacity issues, but we then, when we say we could take 3 or 4 patients today, we never get those patients that come to us. And, you know, we'll do a follow-up call now. We're actually calling care management afterwards and saying, so we said we would take 3 to 4, we're ready, and we don't get anybody. But we're able to care for them. We have the providers, we have the staff, there's no increased costs. And honestly, we have great outcomes and we have great patient experiences. So let's use it, let's shore it up. I think the issue is that we still as organizations don't see ourselves as a system. We see ourselves our own little entities, and there's a lot of territorialism and not wanting to kind of give up some volume when what's best for the patient is to go where they can get the care.
So that's a win-win, right? Because you have folks here that need to go there.
Right,
there are folks
right.
here, right? So do you do it as a transfer, like as a one-to-one?
Well, we could, but I mean, even if I don't have someone that I need for them to take, I can still be a pressure valve, a release valve for them and take some of the ones off of their, you know, that are sitting there. But the ones that they'll want to give are the ones with no payer source. The ones who have a $20,000 drug that we don't carry, you know, it's that kind of thing. But there's others that we could just easily take and assume that care. So I think there's some issue with us seeing ourselves as a system that, you know, in a rural state, I think you have to use every available space and look at it that way. And I don't quite know how we get people on board with that. You know, we've taken the call one step further to now like call care management again and be like, we're really serious. We can take 3 or 4 today. Like, and you still don't get them, you know? And, you know, yesterday we had the experience where we had said we could easily take 3, and they said they were gonna give us a call, and then no one called, and then we mentioned that today, and someone in their system is frustrated because someone didn't do that. There's just so many layers and levels of like.
And did I hear, I'm just gonna highlight the elephant in the room, which is, did I hear that that's working better with one of your academic medical centers than with the other?
I think the system is a little more
universal.
Yeah, well, the system's a little more oiled, but I think that, like, you know, honestly, you know, we have to look at the catchment area, right? Like, so patients don't necessarily want to go somewhere that it's not convenient for the family to visit and that sort of thing. So I think there's bigger opportunity kind of maybe within the UVM network and CVMC in Austin, there might be for some more of those New Hampshire folks and that kind of thing. But it seems like they have a better ability to kind of look at all their places and move patients around. UVM's is not as streamlined. That their reporting structure started during COVID, where they would just report out capacity and COVID rates as just kind of like the state reporting, and now they kind of do it about capacity, but I don't see like those action steps then that happen after that. We can get that right person in the right place and to move them there. And so rather than them pushing patients to us, we're actively now trying to like pull them to us because we have the ability.
And I would just say, Dartmouth has a really interesting story on this, and speaking with some of their leaders at the network level. They said, look, we tried to transfer people for a long time and it was not successful. We realized that because the responsibility for it was with individual hospitalists, and like, they just don't know. Like they have assumptions about your facility. That's not really what they do. So they created a small transfer center at the network level where it's the job of those folks to think about, hey, how do I match up patient A with facility Y? They started it with their own network hospitals, and now they've expanded it to folks outside the network. So I feel like they have as Jill said, like they have a better developed process, whereas at UVM it feels like we're not there yet as far as the process, because we'd love to have a conversation of, hey, CVMC may also, like this shouldn't be just the mothership in Burlington. You could also do this with other pieces of their network if it was a well delineated and successful process.
And my mind has jumped like down the road in a set of assumptions, and so I'm just gonna poke at them a little bit so I don't leave with a wrong assumption.
Yeah.
What I'm hearing is not yet well developed. I'm also hearing self-serving and not necessarily working for the betterment of the whole system.
Yeah, I would just say
so-
though that my experience in politics and in healthcare is don't assume bad motives when plain old like incompetence
Incompetence is it,
might
exactly.
be in play. And so I think anytime I talk to anybody in leadership at UVM Medical Center or the health network, 100% on board with this idea. It feels like an execution problem.
We've had actual experiences.
That's
like
why I wanted to poke at, that's why I wanted to poke at.
Yeah, leadership level, like this sounds great, we should do stuff like this.
UVM will put out a HON notice about capacity and they have no space and they're dying and their CMO will get on a conference call and be near tears and will say we can take 3 and nothing happens.
So I mean, because there's different solutions here for different problems, right? Or similar solutions but what I'm hearing is, hey, there's some opportunity for some quality improvement or process improvement here. Don't assume bad intentions, bad motives. It's there, it's just not running. Or, you know, where I was jumping actually wasn't assuming bad intent, Michael, but instead was the transfer centers come out of the entities themselves. Of course, like if I were those entities, I would want to make sure that that my own organization, particularly when they're feeling some level of instability, is taken care of for sustainability standpoint. And so it's kind of, those have very similar solutions. It's process improvement, but it's also like having the leadership to step outside of yourself, whether that's a whole different entity doing it or stating that that's what the purpose of a center is.
And I definitely have appreciated this conversation because you start to think more about it as a system. Hey, if Dartmouth is sending someone towards home health that's not really home health appropriate,
but should
it
come
could
to
be
your
appropriate to another critical access hospital. It could be us or someone else. And you know, like how do all the patients get to the right place at the right time?
Right. How do the pieces come together so that you know where your, like what a swing bed is, first of all, what the capacity of it is, and what the use of it is, what an acute bed in a hospital is, but also the capacity of the home health agencies and what they can serve. And it's that transfer center is a major component of this conversation, and it's not just, it has to be an entity that really fully understands that.
And there's something that Johanna said that like sticks like a pebble in my shoe every single day. I read Oliver Wyman report, and one of the things that I think a lot about is, hey, I understand arguments about consolidation or regional centers of excellence. That kind of all assumes that the supply and demand curve have met in healthcare in Vermont. And they haven't, right? And so it's like, should we be more thoughtful about capacity as opposed to
right, we have limited
just limiting
resources.
capacity.
It's not, we've been talking a lot about financial resources in this whole conversation, but the fact of the matter is, what I'm hearing in this conversation is it's a capacity and a people resource that we should be as focused on.
Yeah, and we ask ourselves, and we have our own work to do at Gifford. I'm not gonna run away from that, but how does taking away 25 beds here help somebody get a procedure or appointment at Dartmouth or UVM? Yeah, I don't know, nobody's explained that to me.
And I think that it's the same, like, just like they're not thinking of sending an acute patient who's sitting in a hospital bed to us, we also have capacity on our surgical side. So if you're giving someone in another county a 3, 4, 5 month wait list to have a procedure done that could be done here, you know, if we could kind of shift our thinking to what's best for the patient rather than what's best for us as an organization and only thinking ourselves of individual entities, it's the same underlying issue.
Right.
You know, same with primary care or whatever, like who could get this person in?
Yeah, and people will say like, why don't you just affiliate? Then they're like, well, but we're also a federally qualified health center and nursing home and retirement community and independent living community. So we feel like we can work on system flow issues regardless of what jersey you wear. Like in the end, we're all Vermonters.
Yeah, and delaying that person to get that surgery or whatever, I mean, you may be adding additional costs to their overall plan of care rather than getting them in somewhere else expeditiously that might be out of your own personal business model.
Yeah.
It's like, I just don't know how we kind of get folks to think bigger and broader because we need to think as a system.
And I want to pull the home health, the designated agency back in here because I know that when we've talked about system flows issues, a lot of the system flow issues have been here on the post-acute side, but they've also been here on the mental health and substance use side. And that I want to be really clear. It's a combination of both. So is there anything that resonates for you that you're hearing, or from your perspective, is there anything that resonates on this side as well?
I think that the one more of the capacity issues is, of course, that workforce, which we just started to touch a little bit on, but you know, we've seen a lot of places that actually close beds because they don't have the workforce to support them. And whether you are, you know, talking housing for that homeless person who's then going to show up in the ED because they get a hot and cot for the night and they go get a $15,000, $20,000 workup when we could have housed them somewhere else, or I can't get, you know, local folks to be able to move here because there's no housing. I mean, we've got to shore up some of those real just basic issues, but the workforce is huge and housing is a component of that, but also there's not a lot of incentive for our young folks to stay here and work here. Right? Your taxes are through the roof. There is no housing. And, you know, we've got to figure out a way to shore that up because we cannot afford these travelers. That number one, they depreciate and bring the morale down on everybody. They're not invested in the community. We've had great ones. We've also had ones that I would never hire. And, you know, we've got to figure out how we can shore that up and how we can support people to stay in Vermont, get a career in healthcare and work here along that continuum. And one of the biggest bottlenecks in the whole VTSU system is their faculty rate of pays. You know, I mean, those faculty members who need master's or doctoral degrees get paid $30,000 less a year than the students they graduate with a bachelor's degree. You gotta fix that somewhere to get them here, but you know, there's tons of folks who want that opportunity that could shore up long-term care. We shouldn't be paying $60 an hour for folks to be travelers in a nursing home. We need to kind of figure that out. If you opened up those nursing home beds, you'd pull a lot of those 30 or so that are sitting in UVM and get them in the right place. They can't afford to open those beds up when they have to pay $60 an hour to staff it with an LNA. So, you know, it's all very complicated. The workforce is the worst I've ever seen it. I've been a nurse for 36 years, and we have no bench. Absolutely no bench. And, you know, every single time a competing hospital, an area hospital raises something up, it means that I have to do the same because people are just so transient now with their costs. They'll chase a dollar here or there to do whatever. So it's really, really tough. But I think the workforce needs some big focus and some real incentives to try to grow our own, keep our own here. It would help with that whole demographic, that commercial payer base, all of it. We got to get people back here and figure out how to do that so they can live here and work here.
And if I could just add one comment to that is, I know the state's done a lot of work in this healthcare workforce development. I've been able to be part of that group. And it's still a challenge for smaller organizations to take advantage of some of the programs. They're either tied to a hospital, and so again, speaking specifically for home health, or there's a grant writing process that just, we don't have the time and capacity and resources to do that work. And so I'd love to just see a simple system that was more accessible to all parts of the care continuum to do the important work of developing our workforce, because we're all invested in that.
Yeah, we had been
The systems aren't easy.
part of the phase 2 for the Vermont Talent Pipeline. We were good to go. We have 8 students that we're putting through the process, and we lost all of our funding for that. We have still chosen to continue to support those students because that's what we have to do, but we also don't have the ability to do that. And we're, looking at trying to grow our own that way without those additional funds. But there's so many more that are ready to be tapped into that could shore that workforce up.
Where was that coming from? I'm sorry.
It was through the Vermont Talent Pipeline, and I think it was running through AHS, and there was a phase 2 portion of that. Right now, SBMC, a couple other places, were in the phase 1. CDMC has that, and they have a waiting list of folks that want to go in there. We were tasked to be the second phase of that, and lost our funding like June-ish, July-ish, when we had already brought people into the program in like March and April. So, we chose to continue to support those folks. And it's a great program because you partner with CCV, VTSU, they have counselors, they put them through, they get all their available funding that's out there, and then you can kind of connect with them through VSAC, through like a work versus loan repayment kind of thing. And if they leave, the loan would default to them, which is different than if you just paid for it in the past. So it's a great program, but there was additional funding that would have helped them with some salary portion. They would kind of have some work release time and stuff that we do not have the pocketbook for.
So Michael, you started your conversation directly using systems-based thinking and using terms like the healthcare system, which made me sort of like have to take my pulse and go, the Vermont healthcare system, was I missing something?
I know.
But I mean, a system that's functioning well is clearly integrating, coordinating, collaborating, all those catchwords. Are there places, we've heard where it's not working so well, are there places where actually you do see some systems kind of processes going on that are what you would want to help the survival of hospitals and other aspects of the healthcare system?
I'd encourage other members of Team Gifford to weigh in. I mean, I think even though it's off to a slow start, the transfers of acute patients is actually really encouraging.
Yeah, I think a lot of that failure is because one of the things we're trying to do is new. No one was trained this way. No one went to an institution where you went up to a tertiary care center and then you went back down to a rural hospital. No one has ever thought this way. And so we're trying to invent a thing that developed out of a unique situation. We're at a point in time that didn't exist when I trained, 25 years ago. So there are people trying. In terms of like specific examples where it's worked well, I would suggest that the smaller hospitals and their collaboration, most of the hospitals in Vermont, honestly, through VAWS. If you look at the COVID experience and how that was handled and coordinated and organized facilitated by that organization, but through the different hospitals working together and planning and having conversations, worked exceedingly well.
Common enemy.
Who manages the transfer centers?
So Dartmouth has one and UVM has one, and those were designed as a one-way.
Right, can they be jointly managed?
Theoretically, they could.
You have talked about that.
I think that's a common theme that we'll put in the part, like in the parking lot today as kind of a potential follow-up.
If I may, one more. This is not very exciting, but it's necessary. I've really appreciated some of the work that Joe Wooden and others have done on the business side of healthcare with group purchasing. They've gone in with Brattleboro and some other hospitals on the New England Collaborative Health Network, or I think it's going to be called the Northeast Collaborative Health Network, because they now have hospitals outside of New England. And so, we're taking a really hard look at that. We have our own group purchasing we belong to a group purchasing organization, but I'm not sure that it's geared towards smaller hospitals. And so I'm grateful that Joe and others took that on. And it's really nice for us to be able to plug into some of that technical operations work without having to invent it ourselves, right? Because supply chain people are really talented and really expensive. And so I think just, Joe's got a really good story to tell about that piece of the system starting to come together outside the academic medical context.
I'm gonna poke at that a little bit because I know that Joe has now not only extended that to other hospitals, but he's also extending it to the home health agency.
And FQHC,
And it's potential,
notch.
exactly,
Yeah.
potentially an option for that. So, because that's one of the other themes that we have heard in other places, which is we've got a lot of really small nonprofits who are reinventing a lot of the same things in our health and in our broader health system. Some of those are purchasing, others are like finance and other things. So talk to me a little bit more about that and what you see there.
I think that, and if I'm not answering your question directly, redirect me. I think between strong cash reserves and the COVID money, there are healthcare organizations that were able to put off inevitable improvement in their operations. And so now you find yourself, ask yourself the question for everything, how do we become more efficient? Can we do it ourselves, or do we need an outside partner? At Northern Counties, I outsource billing. This place is just outsourced billing. I think you're starting to see that in every single thing.
Right.
Hey, what's the incentive for going our own on this? There are other people who can do this much better.
Yeah, and that's I think been a common theme, and whether it's the outsourcing of things like billing, or it's hey, some of our smaller organizations are beginning to think more creatively about how they partner together, whether it's joining group purchasing, outsourcing billing, or take it one step further, considering rather than just mergers, which are a common topic lately, but how can we use a common CFO or common sets of systems behind the scenes? What are you seeing in that space? And maybe it hasn't hit here, it's hit in some of the other counties pretty hard, but as we look at the fact that Vermont has a strength in a lot of small nonprofits, but we also, that right now is proving to be an Achilles heel as well.
I appreciate you bringing this up because I think Vermont's healthcare system does not enough reckon with the fact that there are trade-offs everywhere.
Yeah.
Right? Like you
There's
can have
no
access,
one
quality, or cost, pick two. Like you're not gonna get all three in a healthcare system. And if you're, in my opinion, looking at Gifford and other similarly situated institutions or FQHCs, you can have independence, financial strength, or expertise, but doing all three at the same time. Like clinical informaticists cost a lot of money, right? And so I think everybody's having that moment of, hey, even if it wasn't a merger or acquisition, how can we share services? And just in case anybody knows anybody who's looking to get into that business for credentialing, please let me know. There are a million little things, whether it's, do I need 100% of a chief information officer? I don't know about that. They're very, very expensive. But I do know that these things can be brought to their knees by ransomware attacks, and that your revenue cycle is going to suffer if you're not great about managing your EHR relationship. So I would say that conversation feels alive and well behind the scenes between healthcare organizations. I always had a hypothesis that the trade groups would find a way to make money out of that, whether it's VAS or Bi-State or somebody else, and nobody seems interested. So we kind of have to go find our own partnerships on that.
Yeah, or at least have some agreement on what the common opportunities, because what I've heard is from each organization I go to, it's a different set of common opportunities and some alignment on what those common opportunities are so that we can connect the partnerships.
Yeah. I mean, I think you want to maintain.
Because I hear you saying behind the scenes it's working, but I'm also seeing like from the outside looking in.
Yeah.
I'm hearing like each organization identified different subsets of
I
options.
think that's fair that the Venn diagram, I'd say behind the scenes, the conversations are happening. Whether they're working or not, I see the same slides you do about FQHCs in Burlington in trouble, at Bradford in trouble, at Lamoille in trouble.
It's not just FQHCs too.
Yeah, I know, I'm just doing the publicly acknowledged ones, right? Our FQHC struggles, right? And so there's a lot of chatter. I think people get nervous about giving up control. I think ultimately you should be looking for control in that Local communities get to articulate what's important to them and get to drive an organization towards that. Local control in that you're going to control every single human and own all those relationships and contracts, not a chance.
Is it something more like,
gonna
as you talk about that balance, I'm gonna poke at a model that I've seen. Primary care health partners, for example, buying group, not an interest in controlling. Is that kind of what you mean in terms of the balance? I'm not saying that they're like the type of organization that we would do, but for a long time, they've supported independent practices and said, what are all the things you need? Let me go out and help you get those things.
Yeah,
but we're not gonna control you.
I think
How
that's
your
right,
destiny
and,
is.
and I know there are hospitals in Vermont that have management companies behind them.
Yep.
Because they need analytics on demand. They
Yeah.
need to understand their business on demand. So I think that is the kind of thing that I'm talking about.
Analytics, finance, buying power, those are the three things
Yeah.
I've heard.
IT expertise,
Right.
security. And then not everybody, and we probably like other hospitals, we don't employ all our physicians. We have contract labor. Running your own radiology shop as a critical access hospital, pretty difficult, right? And so we have contract partners for that, anesthesia, things like that.
How's it resonate with the other groups? And then you were gonna say something, and we'll come back, I promise.
Yeah, I was just gonna share that the VNAs of Vermont system has also had similar conversations about how might we partner on a shared service type model. And for us, it's a little bit different because we don't have some of the other levers that the hospitals or the FQHCs have in terms of group purchasing, and because we're not big buyers and things of that nature. So for us, it's really more operational, and we seem to get stuck because we're all on different systems, right? So it's hard to have someone who's supporting billing and revenue cycle if you're not all on the same, EMR.
So common EHRs and billing
So-
systems.
Yeah, so those are some of the barriers, but I would tell you that for some of our smaller rural agencies, and even, we're mid-sized now at this point, being able to share in those expenses would be hugely helpful, in terms of the infrastructure and the overhead that's required with our, every single VNA in Vermont is operating at a loss right now.
Yeah. And I've heard some of these themes from years ago, and so I'm just gonna, again, check one of my assumptions.
Yes, sure.
Oftentimes it's been larger players who've been the ones who've come to the table and said, hey, we wanna provide those types of services, and there's been some skepticism to that. What I'm hearing now is behind the scenes, maybe some of the smaller players can come together in a little bit of a different way, because the bigger players were scary. They just wanna, because it didn't, years ago, for example, UVM wanted to buy an EHR for all hospitals. There was like, whoa. Now folks may be saying, well, maybe that was a good idea.
It was a good idea.
But, yeah.
Yeah, I think part of it is scary, and then just speaking for myself, there's been this persistent question that's been finally answered of what's OneCare's role in this, right? As the convener of things that were supposed to be shared and system-wide. And so as the ultimate fate of OneCare has become more clear, it's easier to make decisions, and then obviously there are financial incentives. The financial condition of healthcare organizations in Vermont is worse now than it was before. I think those two things together create a motivated group of people to go try to figure some of this stuff out.
Yeah, there's some irony there.
Yep, there is.
Secretary, if you don't mind, I'd like to give a couple examples of new programs that are working. There's bumps along the way, especially around shared resources and shared staff. And that is with the enhanced mobile crisis response program that the department initiated in January of 2024. And that model targets our designated agency system, who are subcontractors of one designated agency. So HCRS holds the main contract. But it allowed some staff flexibility to cross county lines, to cross into other towns and utilize telepsych when that's available for a second responder. But that is a model that's working, where there's opportunities to share staff and resources that promote agencies sort of working together Also streamlining documentation. Most of the DAs also have separate EHRs, although there's a few that have the core 4 that are on the one. So there are some models that are working within the state that it might be helpful just to do knowledge sharing around that, because I think of your situation and maybe there's some opportunities for lessons learned there. There's definitely been bumps, but it's growing, and I think we'll see some positive impacts, not only from communities getting good service, but also from the agencies having a little more fluidity between each other.
State, regional, and local services.
Correct.
I'm not, like, it's been a long time.
It's okay, I probably all forgot, there's been all this good things that my original was to your question of 5 years of the vision.
Yeah, so go for it.
But I don't wanna lose, I think the past 5 years coming out of COVID has absolutely tested us to be innovative, collaborative. I know we use collaborative word loosely, but we had a necessity to function. We work with another DA for child psychiatry. We work with Washington County to help our after hours emergency. As a smaller designated agency, we have got to do that because we can't afford everything individually as an agency. So I think our network is getting better at how can we share our resources and our knowledge to raise the bar for everyone. The work, Jill, you were just talking about bench depth. And I think my concern when you were talking about 5 years, 10 years, we have an aging population, but we have an aging workforce. And I really worry about as our workforce ages out, we don't have enough human resources coming in to support this really significant need. So we're losing expertise that is really helpful at training the new workforce. So I just worry about that gap. But I think we get creative. We're doing our own leadership academy to develop future leaders. Because the idea that as a position, a clinical director turns over, that I can recruit one in that I can afford. So how do I develop within those leadership skills? How do we partner with our local college and university system to have a pipeline that we can train and develop interns? So just that is absolutely essential, and I feel like we've gotten really good at that because it's the only way that we're gonna survive into the future. Anyways, just there's a lot of good things, and then there's just significant challenges that I don't fully have the answers to of how we're gonna meet that need over the next 5-10 years, because that demand doesn't seem to be turning the curve.
And our demographics are against us in terms of that demand.
Yeah.
Because there was already an identified nursing cliff prior to COVID, right? And that was 2026 or whatever, and 2 years away from that now. But the pandemic exploited that tremendously, and so we lost a lot of the healthcare staff as a result of COVID just retiring early or whatever. And so we had programs that targeted folks who were retired to come back into the workforce, but I don't think there's enough bodies in that general space at all. And so I just want to honor that I hear you. We oversee a hospital. We are experiencing the same things at the Vermont Psychiatric Care Hospital, lots of travelers, and then there's just nobody coming in to work there unless they're on a border.
Yeah, we've looked at, other workforce pools where, we're partnering with an organization to bring in foreign nurses that are either trained here in the US, and we support their work visa and that sort of thing. And there's just not enough, even if you had the programs, there's not enough of a pool of the workforce to meet what we have for the demand, for sure. It's shored up our OR. We have, will be 4 nurses coming into that program that, we need to look at that as well, that immigration policy, looking at nursing as one of the STEM programs, because you can't bring them in for positions unless it's at least a bachelor's required for the job. And what COVID did is it let us drop our standards. You see LPNs doing stuff in places that they hadn't done for 20 years. Not because that's best practice, not because our patients aren't sicker, but it's only because it's a body.
And then
Because we
it's not
changed-
that
we
they're
changed
loyal to Gifford. And we see that too,
That's my mobile.
CVMC raises something, BPCH needs to raise something, and then it's Copley, and then it's Lamoille, and so, just that flexibility of the nursing staff to be able to go wherever the dollar is. We're certainly seeing that as a huge trend, but enhanced mobile crisis really took that away. Everybody gets the same. So there's not that opportunity for people to go work for the Clara Martin Center Mobile Crisis Team for a lot more or a lot less, sort of even the playing field in that way.
But for therapy, it is a
Therapy.
race of, if Dartmouth raises their salary $30,000, I'm $40,000 off.
Right, it points out that the workforce crisis, like we've talked about it for nursing for 20 years, and we've neglected that conversation with some of the other allied health fields.
Yes.
I think it does make me optimistic that people seem very engaged. There was one of the silver linings of the Oliver Wyman report is that, hey, you're gonna have to deal with this stuff as a healthcare system. And then not to get into the politics because we're here to care for everybody at Gifford, but I think with so much uncertainty at the federal level, both in the administration and the 119th Congress, solutions are gonna be local, like the work's gonna happen locally. I'm not expecting huge help from the feds. And so I think people are like, okay, so maybe we should have done this earlier, but how are we actually gonna take this on and change? I know that when I used to sit on the state side, you'd come out to try to have a good conversation and the whole thing would be about funding. So I tried not to talk about funding for an hour and a half. I would just make one note, both in the all-payer model and potentially under a head, the stated keystone of the model was primary care, right? We're a federally qualified health center. We offer primary care services throughout this region. We lose money on every one of those transactions. And so I would just note that it's a real challenge to continue to operate primary care when each transaction causes you to lose money.
Yeah.
And then we look at downstream things like our operating room capacity. People can't just show up and ask for surgery, right? They need to have a relationship with primary care to be able to get to the appropriate place, whether it's us, Dartmouth, home health, our colleagues in the designated agency world. And so that, two things are equally true. We can be more efficient, and we'll figure that out in primary care. But we're probably gonna need some help at some point with primary care funding.
And that's one of the things I'm excited, if we were to move forward with the AHEAD model, is it does provide at least Medicare's portion of some additional investment.
Yep.
So I want to be conscious of everyone's time. We're about 5 minutes from needing to wrap up. I wanted to thank folks for your willingness to come together. I know everybody here is incredibly busy. To take an hour and a half out of your day to sit back and have a more global and strategic conversation can often be both challenging and exhilarating. So thank you for that moment, because we are facing some real challenges and some real opportunities as we go forward. Knowing that we've got only a couple minutes left, are there any last pieces, things that folks wish that they'd said? There are a lot of folks who haven't taken the opportunity to say anything yet. Are there any last, I wish I'd said this one more thing? And if you don't today, you can always just drop us an email, drop us a line.
I have one thing. So we talked to Rebecca from Gifford. We talked a little bit about some things that are working well and some care gaps that we were talking about addressing. And we have a system that we've used here with a couple of the local EMS units that we call house calls, which is sort of meeting some of those gaps, some of the social isolation, some of those patients have been discharged from the hospital, need blood draws and other things that perhaps VNH can't step in and do. And that has actually worked really well across our region. But we've also been funding that through grant funding so that we help offset the cost of the EMS units. And we have actually seen it, even though it's going really well and our partnerships are strong, really dwindle because of the workforce, because there are not enough rigs that have personnel on it to be able to handle the volume of need that we have. And so I just leave that as something that I think really works well. It's a really great collaboration using the term as it's meant to be. And it actually does hit a couple of those things, the social determinants of health. There's eyes on people's homes to see what they're missing so that we can get some extra support and meet that care gap, but there's not enough people to actually do the work.
Great, that's a great place for us to kind of close out, because that's where we're headed almost directly next, is to have a conversation with our local EMS folks. And so we look forward to that. And again, wanted to thank everyone. Monica probably also has some words of thanks there too, but thank everyone for taking the time today. It's always really helpful I learn something every time I take away, what are some of our next steps every single time that we do a local visit. And there's often common themes, but there's also local challenges. And so I appreciate your willingness to share those with us today.
Thank you.
Thank you for coming out.
I'm appreciative of the systems conversation versus just the focus on funding. I think that we understand the funding issues. Well, we at least are aware of them. Understanding them might be a bridge too far, but I think we are really aware of them. It's really good to hear the systems conversations and the way that you're thinking about it locally. And I guess I probably should have said this at the very beginning, but the governor is unable to be part of this today because he has, for the first time, succumbed to COVID. So he's in his office sort of locked in and using, as I shared with Dr. Levine and Commissioner Groves, kind of an isolation basket. You can only put stuff in there and then he sort of sneaks down and takes it and then sneaks back out.
Ooh, what do you put in there?
Okay,
No.
we're not gonna get BDH going on infection control.
Some chicken soup. But anyway, I'm sure he'll be hearing this conversation, so I'm sharing as much as I can.
Got it.
So thank you.
Good to see you.
Thank you.